Good morning, everyone. I'll check in my phone so you can hear me. Can you hear me okay? Thank you. Okay. My lips all the time. So thanks for coming and for everyone who's online. There's some good lead-ins from the discussion ahead that will hopefully make some sense about sentinel lymph biopsy. So this beautiful little tree-like picture here is a lymph node, and we're going to talk about some of the intricacies of lymph nodes and melanoma and why they matter. In the operating room, though, they don't look like this. They just look like almost like a small piece of fat. Lymph nodes, when they're normal, are pretty small, a pea size or something like a little bean. So we can't see this unless we have Dr. Florell showing us under the microscope and some intricate pictures of lymph nodes. I'll show a few more of those in a minute. So we're just going to talk about a few things today. Why lymph nodes are important. What is their role in melanoma? Many of you in the room or online may have already had this procedure done to educate others about it. Then we're also going to talk just a little bit about what we've learned from studies about melanoma and lymph biopsy. So for full disclosure, I have not seen this movie, but it's called Guardians of the Galaxy, and I think it's perfect analogy for lymph nodes. So as I start talking in the clinic about sentinel lymph node biopsy, get ahead of myself, often patients will say, wait a minute, what is a lymph node? That's a great question, because until now you may not have to think about those. So Guardians of the Galaxy, so lymph nodes are constantly surveilling the system, your system, for invaders. They are very important fighting infections, so bacteria and viruses that are trying to assault us. The lymph nodes in the lymph system are meant to kill invaders. When it comes to cancer as well, cancer may be coming from inside, it is an invader, and our immune system is trying to respond also to melanoma. Some of the drugs that Dr. Huntsman and Huntsman are using in melanoma are trying to accentuate that response in our immune system against cancer. So our lymph nodes are there for a reason and for our own good. This picture in the green shows our lymph system. So even though at surgery we're just sampling one or two of these lymph nodes or near where a melanoma is arising, this complex system is throughout our whole body. So the green lines show how the lymph system is connected, and you look closely, you see little dots, and those are the lymph nodes. We have a lot of lymph nodes internally that we can't feel when we do an exam in clinic, but the ones we can feel most easily are in the neck, in the armpits, and the groin. So if you've seen any of us for exams, you're always pushing on those sides of the lymph nodes. It's an interconnected network. And if you have had melanoma and been treated for melanoma, you may know this very personally, that melanoma can get to a nearby lymph node, but sometimes it can also show up in other lymph nodes distant from where the melanoma started, and that's because of this network. So looking again at just a close look at what a lymph node looks like inside, at the top of the screen, this fluid that's coursing through our system and in our skin is picking up these proteins maybe from a bacteria you were exposed to or from a melanoma cell that's moving through the system. That when it goes through the lymph node, it really triggers an intense immune reaction. So there's a lot of crosstalk happening between the lymph nodes, between our bloodstream, to get our system to mount a response against whatever the invader is. It's important in cancer that this relationship exists too. That on the left side of the screen are the red arteries. So we have all these arteries supplying our system throughout our skin and throughout our body. On the right side of the veins, the blue ones, they communicate in getting blood to our system, but those green spots that are intersecting in between, those are the lymph channels. And so these are intersecting parallel highways in our body. So the lymph directly interacts with the bloodstream. And we know that in melanoma this is the case because melanoma can start in the lymph nodes but move to the bloodstream and create other problems with the patient. So this is an important relationship. So when we do the sentinel node biopsy in the clinic, or we talk about it in clinic and into the operating room, what we're talking about is mapping this lymph system so that we can identify as early as possible when melanoma cells have left the skin and move to the lymph node. Most melanomas go by way of nearby lymph nodes first. So most melanomas do not hop into the bloodstream and spread everywhere. People worry about that, and rarely that can happen, but most melanomas go to a nearby lymph node first. So on this one, the melanoma is just on our left abdomen by the belly button there, and we're showing how we can map out the system of lymph to find the key or sentinel lymph node. So sentinel we can think of as first, or the guard of the lymph node basin. And we don't need to take out all of the lymph nodes to prove that any of them are abnormal. This technique helps us just isolate one or two of them. The lower left there shows the dye in blue. We use two dyes. We've gone through this, you know this. The day before surgery, typically, we do this injection in radiology with the radioactive dye. The radioactive dye hangs around for about a day, so it stays in the system and in the lymph node. The day of surgery, when you're asleep under anesthesia, we inject the blue dye. It does the same thing. It masks along those pathways. So the blue dye we can see really easily in the operating room. The radioactive dye gives off a little radioactive signal, so we can take that out with the wands that we use by the dye counter. So ultimately what we're seeing is here on the lower right, a sentinel node that is blue, often to our naked eye, and it picks up that radioactive signal as well. The yellow around it is fat, so lymph nodes are embedded in fat, and when we take them out in the operator, they often look like little pieces of fat, but they're not, they're more than that. And the little silver things are just retractors we use to expose the area. Dr. Morton was a surgical oncologist who really pioneered this technique, and I just mentioned him because he's now passed. He died in 2014. But, you know, we always are building on what others have shown before us, and he really perfected this sentinel node technique. He worked at the end of his career at John Wayne Cancer Institute, which is in Santa Monica, and he treated John Wayne. And does anyone know what John Wayne died of? Yes, stomach cancer. He apparently also had, I think, another cancer. He died of stomach cancer. And he met Dr. Morton, because Dr. Morton was really interested in cancer vaccines. And something they've been on to study was cancer vaccine. And cancer vaccines and melanoma are still really of great interest. Again, seeing how our immune system can fight cancer. So he worked with John Wayne on a cancer vaccine study that John Wayne died of stomach cancer. So why do we need to do sentinel nodes for melanoma? So why is it still important in 2019, even with all of the great advances in immune therapy and all that has really changed the outcomes of melanoma patients in terms of what they're receiving in addition to surgery? Why do we still need to do this? Well, in my view, there's two big reasons to do this. One is that melanoma can be found earliest in the lymph node when we do a lymph node biopsy. So the disease we're finding is very tiny. In patients who have an abnormal sentinel node, if they had a PET scan or a CT scan before we did a sentinel node biopsy, which some patients do, that scan cannot detect the disease in the lymph node. It's too small. We can't do it in the clinic when we examine the lymph nodes. This disease is so tiny. So this is the earliest way to detect if melanoma has moved. And because of that early detection, we can then give the patient the appropriate stage. As Dr. Bowman and Farrell were talking about staging, it's critical in how you're treated for melanoma in 2019, and especially whether you should receive immunotherapy or not. So does it matter? Yes, it does, as far as when we find the disease. It makes sense it would matter to find it earlier. I'll show you a few pictures to emphasize that. So this is a good follow-up to what Dr. Farrell was talking about. This is kind of the slide that he would be looking at in his office. It's a lymph node. This is the edge of the lymph node. This is the fat. We talked about lymph nodes are often embedded in fat. And just this tiny little area that is showing up as a melanoma cell or cluster of cells in a big lymph node. So it's a tiny amount of disease we're finding. The incision, if you've had this done, is small. It's about an inch incision under your armpit or groin or neck. It heals well, few long-term side effects. The risk of causing swelling in your arm or leg from taking one or two lymph nodes is exceedingly low. And we know and learn that taking this disease out early can reduce the risk of melanoma coming back and prolong survival when we find it at an earlier stage. The later stage melanoma in the lymph nodes is a very different picture for the patient and for us, the surgeons. So before sentinel node biopsy was really perfected in the 1980s, many more patients presented like this. So what this is a big clump of abnormal lymph nodes with fat. So the yellow you see is fat, the black is actually melanoma. Not all melanoma looks black in lymph nodes, but some of it can. And before Sentinel Lymph, this is a much more common presentation to have a patient come in with a mass under their armpit or in their neck. Now, we still see these patients in the clinic. Some patients, they have what we call an unknown primary, so they never had a skin melanoma, but they come in with a mass in their lymph nodes with melanoma. So we are still seeing these patients, but they're much fewer because of finding disease early. The problem when we have this is that all of these patients need a big incision to get that disease out. I'm not talking anymore about an inch-long incision. They all have a drain tube, and they're at risk for getting swelling in their arm or leg. So finding disease early decreases the side effects the patient experiences later, and the outcomes are better. We already started to talk about staging, so this is a good follow-up, but this really emphasizes why sentinel node is important. So as the speakers before mentioned, stage 0 melanoma is completely treatable. People do not die at stage 0 melanoma, so this is where we want to be diagnosing melanoma. Stage 1 melanomas are still thin, but they're starting to get more risk at moving to lymph nodes. Stage 2 melanomas are much higher risk of moving to lymph nodes, so all stage 2 melanomas should be having sentinel node biopsy done, and some stage 1. But the whole purpose of doing this as far as getting accurate staging is that we're trying to identify patients that are really stage 3 melanoma, which is lymph node involved, but is not yet visible on X-ray or on our exam. Because these patients will be seeing a medical oncologist to talk about immunotherapy or these targeted treatments that are available. So there's been some confusion over the last couple of years because there's been some advance in what we do with the lymph nodes if an abnormal lymph node is found. And in the clinic, I've noted there's some confusion regarding what I just talked about as far as checking the lymph nodes versus some new information about what we do with the remaining lymph nodes if we do find one that is abnormal. So as I mentioned, after 1 or 2 of these lymph nodes are sampled, there may be melanoma found in that lymph node. Before about 2017, where we participated in a large study that showed the results I'm going to show on the next few slides, we would go back as surgeons and take out the rest of this web of lymph nodes. So some of you may have undergone that, where we went back and did a bigger excision, took out all the rest of the lymph nodes, and checked those for melanoma. For years, though, in practice, we can notice that most patients did not have additional disease in lymph nodes beyond their sentinel or key lymph nodes. The risk seems to be about 15 to 20% of patients would, but that was never really studied in a direct comparison until a study that we participated in called MSLC2, the abbreviation you may hear. But nearly 2,000 patients around the world went on this study. So all of the patients have sentinel lymph node biopsy, as I described. Half of them, and all of them had all the patients in this study had an abnormal sentinel node biopsy. So if it was normal, they were early stage and didn't go on the study. But if it were abnormal, they were put into one of 2 groups. One group had all the rest of that web of lymph nodes removed at surgery, which was the standard treatment at the time. The other half had ultrasound follow-up of their remaining lymph nodes. So just like an ultrasound for checking a baby, they had a wand over their lymph nodes to check those lymph nodes intermittently over 5 years' time as a way to screen them instead of taking them out. Again, assuming that most of those lymph nodes were going to be normal from our historical experience. So what that study showed was that, in fact, yes, it is safe in most patients to leave behind the rest of the lymph nodes. So this is a survival curve. It's showing survival over time. We have 10-year follow-up on many of those patients. And as an aside, about a quarter of those patients came from Utah. They were the second highest enrolling center in the world for melanoma because of all of you who are facing this disease and willing to go on clinical studies. So what it showed, though, is that this red and blue line overlap. And one line of the patients had all their lymph nodes removed after an abnormal biopsy, and the other had their lymph nodes left in. So it showed that survival was similar. There were some other findings to the study I won't get into great detail, but the bottom line in 2019 is that if we see a patient who has an abnormal sentinel node biopsy, most of those patients do not have to go on to have the rest of their lymph nodes removed. They're instead followed with an ultrasound. But it doesn't take away the importance of doing the sentinel node biopsy in the first place. And that's what's been confused a bit on the internet and in other discussions is that this study meant that sentinel node biopsy is not important anymore. It actually means the opposite. It's still really important, but that many patients can have the rest of the lymph nodes preserved. So, just to conclude, lymph nodes are there for our own good. They're key immune players and protect us from outside invaders. Melanoma that is spread to the lymph nodes is of higher stage, and the way we find that disease earliest is with lymph node sampling. And when that lymph node biopsy is done, it technically removes the diseased lymph nodes so it can no longer grow in that spot of the patient. And even more important, probably, it identifies those patients who need to have additional treatment beyond surgery. So to finish, as Sam mentioned earlier, we do have an AMIT melanoma walk. Now this will be our third year running with AMIT melanoma sponsoring. We're meeting in May, which is Melanoma Awareness Month. I know this is way in the future, but it's Mother's Day weekend in May. And our colleagues from Myriad Tours here have really been very supportive of this walk as well. So May 9th, 2020, keep your eye out for more details.
Let's get the Sugar House working.
Yes, so it'll be Sugar House Park. It's an easy venue, easy to park, easy to walk, and bring your kids and family. It's a way to raise money for melanoma research. Thank you.